Thank you very much for the introduction. Thank you very much for the invitation to this seminar. I'm just interested how many of you are working clinically with cancer patients. How many of you have seen serious endocrine adverse events? 67% of you, bless them. I'm an endocrinologist here at Oslo University Hospital, and I'm collaborating with the cancer department and Radiumhospitalet on these patients. The patients I present here are from a collaboration between Radiumhospitalet and our department. So we have a onco-endocrinological outpatient clinic. Let me come to the first case. Anna was 34 years old when she was diagnosed with a malign melanoma and extended excision and with positive lymph nodes. She received first tyrosine kinase inhibitors, developed intolerance, and later on in 2015 and 2016 she developed or was diagnosed with metastatic disease in multiple organs. She was included in a clinical study at the study center at Radiumhospitalet and received both nivolumab and ipilimumab as therapy for her cancer disease. The first dose of medication was applied in the end of November in last year, and she was routinely followed up weekly by phone calls, and with a little bit longer interval she was examined clinically and with laboratory exams. From the end of January, she reported some fatigue and muscle pain, and in the lab results she had, as before, she had totally normal thyroid function values. In the end of November, she developed some diarrhea, not affecting her very much, but it was reported and not changing the therapeutic regime or not necessitating intervention. Fatigue and arthralgia developed in the end of March, and at this point of time TSH, the hormone from the pituitary that is stimulating the thyroid gland, was a little bit lower. This might indicate, in some cases, a slight hyperthyroidism. Some days later, follow-up samples were taken, and now she had biochemical hyperthyroidism, as one of the three hormones was moderately elevated. At that time she didn't have any more specific signs of hypothyroidism, which are, for example, tachycardia, palpitations, sweating, or diarrhea and fatigue of the more unspecific signs. A week or so later, she was admitted to the hospital with increasing fatigue and she had to be checked more thoroughly. And here a little star to remind you in a minute or so. She didn't report something here in the middle of May, which she didn't think was so important. So just remember this star, it will come again. She was then admitted to the emergency room at Radiumhospitalet with a known hypothyroidism and with suspicion or we had hypocortisolism had to be ruled out. What is hypocortisolism? Anybody who knows or is not aware about it? Who knows what hypocortisolism, low cortisol levels, mean clinically? Nobody? Then I've got to explain. There is a disease called Addison's disease, which some of you might have heard about, where the adrenals do not produce any more of this most important, one of the most important hormones, cortisol. And without cortisol in your body, you, after some days, you will die. You need cortisol. So this is a potentially dangerous situation that had to be ruled out. First, the thyroid levels, they now showed a clear hyperthyroidism of moderate degree, and she had a pulse rate which was also clearly elevated, but otherwise no specific, more specific symptoms of hyperthyroidism. But she had a absolutely low cortisol level here, the hormone produced by the adrenals, and indicating that the problem are not the adrenals but another organ. Which organ might that be? You're not allowed to answer. I will stand here until somebody tries. The pituitary, exactly. So this is pituitary insufficiency with the most important hormone the pituitary produces, leading to an adrenal insufficiency, potentially life-threatening, and explaining her tiredness and fatigue. So she had in her past history, she had migraine, and here comes the star. She had a migraine attack, she thought, on March the 11th, but it was different from her other migraine attacks and probably more comparable to that case that you presented. It was not very strong, but it was stronger and more long-lasting than her migraine attacks, and it was bilateral differently, what she otherwise has, unilateral migraine. And it lasted 1 week. A pituitary MRI was performed when she was admitted. In her case, I would even say it doesn't have to be a pituitary MRI, differently to your case, where the patient still had a headache, and it showed, in my eyes, a normal pituitary, but the radiologist was perhaps a little bit biased, and he could see a little bit pronounced pituitary stalk. So basically a negative MRI, I would say. This is a different case, more similar to that you had, a man coming into the emergency room with very strong headache, and an MRI was performed, and you see here he had an absolutely similar to your case, an tumor, an inflamed hypophysis, so it's not an adenoma. It could be mistaken, but this was the reason for his headache, and that is what we endocrinologists call TELT-like enlargement of the tent-like enlargement of the pituitary. This very similar to the tent I had in the 70s and 80s, and even the same color. But that was not the patient we had. If the MRI changes are missing, it does not exclude that there is a pituitary affection. And often there are only slight changes. And if you don't have a severe headache, there is not a strong indication for an MRI. So here we see exactly the same curves that you showed us, with a TSH which was normal between the two lines before she developed the hypothyroidism. Here she develops hyperthyroidism and then gets back to normal after a while. Parallelly, she developed low cortisol. There weren't any cortisol measurements in the start, and this is not a mistake or so. We can discuss that if it should be routinely taken, but on clinical suspicion it was taken and it showed very low values. And as I told you, it's a life-threatening condition. This patient was treated. The question is, how should she be treated? Should she be treated with a medication that you gave to the patient with a hypophysitis, with a large tumor, with high doses? Or is it enough to replace, with a much lower dose of steroids, her pituitary insufficiency? How would you answer in this case?
So, there is some data to suggest, so 80% of these folks will require lifelong replacement. There is some data to suggest that initial pulse of high-dose steroids may save some pituitary glands. So instead of going directly to hydrocortisone replacement, perhaps an early phase of high-dose steroids is not unreasonable. That's what we do.
Do you remember what she got? You talked to Anders?
Yeah, she got high dose of steroids.
Yes, she got a short course of high-dose steroids, and but it was much shorter than the other dose regimes we saw. And then she went over to an only substitution therapy for this, we think, permanent ACTH deficiency. And she's doing well. I saw her last week on a substitution treatment with corticosteroids. So the diagnosis in this patient is an immune-related adverse event with a thyroiditis with a so long typical cause. We don't know yet if she's going to develop a permanent hypothyroidism. And from the observational data, we actually don't know if some of these people will recover or not. It's not so important to know this exactly. And she has hypophysitis with a pituitary deficiency in one of these functions, and the most important functions of the pituitary. In her case, all the other functions like thyroid, steering function and the gonadal function are working properly, and that's a pattern we see in most of the patients with hypophysitis. Very important that these patients are educated and know what to do in case of intercurrent disease, for example fever or inflammation, and that we give the patients the card with the medical information so that they don't have to argue in an emergency room, I have to have more cortisol in a stress situation like an emergency admission. And we have to record it in our electronic health records that you get a signal, well, be careful with these patients, give him more cortisol if seriously ill. Somewhat from studies you probably know very well and even better than me, is in the combination treatment with ipilimumab and nivolumab, you see quite a high number in this study of 12% with hypophysitis, a large number of patients, 1/4 with thyroid disturbances, not all clinically apparent, and some patients, probably most induced of nivolumab, with adrenal failure. And in total, more than 1/3 of the patients had reported endocrine side effects. So to sum up, the typical and most frequent endocrine side effect of checkpoint inhibitors are hyper followed by hypothyroidism, primary adrenal insufficiency, Addison's disease, or secondary adrenal insufficiency after pituitary inflammation with a hypophysitis and pituitary deficiency, or in the pituitary symptoms with headache of an inflammatory enlargement of the pituitary. In some cases, as we already have heard, perhaps more nivolumab than in ipilimumab, type 1 diabetes-like disease occurs. As a matter of time, I think I will skip this. It's showing the same as before with a typical hypothyroid phase of thyroid affections. But I will want to go through this slide of a study just recently published where they found a 3.3% incidence of hypophysitis. No patients in this study required high-dose corticosteroids, but they got all physiological replacement therapy. 2 patients died during follow-up, 1 due to disease progression, but 1 probably due to misdiagnosed adrenal crisis not correctly treated. And this is one of the most important messages. Hypocortisolism has to be suspected and has to be adequately treated. And also in this study, no recovery of the ACTH, the cortisol steering function, was detected. So to sum up, we see after immune checkpoint inhibitor treatment, well-known autoimmune endocrine diseases, but the time course and the clinical presentation differs from that what we classically see. For example, the hypophysitis we almost never see, but now we have quite a lot of these patients. And if undiagnosed, it may be fatal. So we endocrinologists, we can assist you oncologists in finding out, is this an innocent incident laboratory finding which we don't have to take action, or is this perhaps a life-threatening disease? And the endocrine adverse events, they affect, of course, the quality of life of these patients, but they should not be a limitation for further oncological treatment. And we should, opposite to the other specialties, we should try to facilitate oncological treatment and to continue, and it doesn't have to be stopped in accordance with what you have said. So, thank you very much.